recording and
Okay.
then we can go ahead. Yep.
So this is the second version of the framework.
Mm-hmm.
I tried making it a bit more specific to our study, and
Mm-hmm.
I noted down some questions from last time that
Mm-hmm.
I should address, and I kind
Mm-hmm.
of incorporated those into this version.
Mm-hmm.
So I would say like the overall study purpose and like the objective is to evaluate the accuracy slash reliability of our software in tracking sit to stand test results compared to physician observation and current gold standards. And I would say the significance, like why this is important and why we're even doing it is because accurate and accessible sit to stand tracking can enhance myositis progression monitoring and reduce reliance on in-clinic testing.
Mm-hmm.
So yeah, like being able to take a video and upload it will make it a lot more accessible, a lot more easier to um what's it like to just do testing as much as possible to uh
Mm-hmm.
get more current data.
Yep.
And then I would say like the overall research questions are how accurate are the software measurements compared to physician observations and the gold standard tools? How does patient movement quality affect the software accuracy, meaning that if someone can't stand up all the way, will the software still be able to collect data? And then what accommodations are needed for patients with disabilities to assure usability? Because we need to account people who might not be able to stand up all the way.
Mm-hmm.
So inclusion criteria, I don't know, maybe adults 18 or above diagnosed with myositis or related mobility impairments. And then they
Mm-hmm.
should be capable of performing sit to stand with or without minimal assistance.
Mm-hmm.
And then exclusion criteria, severe cognitive or vision impairments preventing testing completion or physical conditions that contradict with STS, such as like if someone had like a recent surgery, that's obviously going to affect the data because if you had surgery, you might not be able to stand up all the way.
Mm-hmm.
And then for data collection and setup before testing, you would need to collect patient demographics, disease history, and serum markers relevant to myositis. So some of the serum markers would be like creatine kinase or aldolase, and then
Mm-hmm.
baseline physical function, so like muscle strength or flexibility, just so you can have something to compare to.
Mm-hmm.
And then for actual testing, use standardized STS procedures, so like 5 repetitions or like just one single time movement. And then record
Mm-hmm.
tests using video and physician observations. So the video would be
Mm-hmm.
like software, and then physician observations, just so we can compare to see if we're getting reliable data. Apply
Mm-hmm.
reflective markers or use AI tools to enhance movement tracking. This is like an example of
Mm-hmm.
the software being able to kind of frame the subject of the video.
Okay.
Conduct conduct tests at consistent times to minimize variability. So, for example, you would do the test morning before medication or as soon as someone wakes up, and you do this every single time to make sure there's not like any differences.
Mm-hmm.
Gold standards for like
So
so
before
current gold.
before you go,
Mhm.
before you go, I do want to stop you, and then can you bring up that PowerPoint presentation that you had made? So if we just so you're on the same page, am I telling your name correct? It's Sophie, right?
Yeah, it's okay.
Okay, perfect. We don't want to get anything wrong over
Mhm.
here. So in short, what we are trying to do is we found this software tool where we are able to detect, identify and isolate the person from a video, any video, right? So given we are able to do that through technology, we want to test how accurate it is when it comes to a real world clinical test that we are already doing. The clinical test is a simple sit to stand test. When I say a simple sit to stand test, over a period of 30 seconds, I will ask the patient to stand up as many times as possible. Right now, the guidance is you can use support, you cannot use support, that's up to you. They should just stand up. And what the physicians record is are they using support or not? And the second thing they're recording is the number of times that the patient is able to stand up. That's it. So it could be over a period of 30 seconds, they stood up thrice or they stood up twice or they stood up 10 times. And then this is visit zero. Now, after 60 days or 30 days, when the patient comes for a follow-up, you ask the patient to do the same test and then you record the same value. First time it was 3 and the second time it was 6. Now you know that the patient got better, right? Here, the question that we are trying to ask is if we get more granularity, looking at, hey, how high they stood up, or how, what was the rate of ascent, and along with the counts, is that a better metric to compare apart from just having the counts? That's the question that we are trying to answer. You can show the next slide. Right? So this is how the code does it. It isolates the human and then it generates the graph. So if we can you can show the graph next. Yeah, it generates a graph like this. So our question is this better than just having counts?
Okay.
Right? Now you go back. Are we
Uh,
clear on what our goal is?
So we are comparing the two results. If
Yes.
these are better than that or not. Okay.
Yes. First thing is we need to know that, hey, what is the physician already doing? He is taking down the number of counts, right? First thing is, can the machine do the same, right? Can it also count by itself? So first, so that any chance of error in human will be removed, right? So that it is able to do. And even though phys through physics, you know that it will do it, you still have to validate the tool, right? So that's what our study is looking at. So now, Hasini, continue.
okay, where did I leave
You
off?
were in the gold standard
Yeah.
comparison.
So the current gold standards would be like motion capture systems. This essentially,
Mhm,
these kind of do what the software does, except it's a lot more complicated because you have like these big machines and they're doing a
mhm,
lot of like, complicated data analysis. It's just a lot more complicated. And the software that we have, I think, just kind of simplifies it while collecting the data that's actually useful instead of just a bunch of extra stuff.
mhm,
And then you have assessed metrics. So a couple of these metrics would be movement quality, repetition count, time. This is just like kind of like the basic. You do the sit-to-stand test and you have someone like a physician collecting data while looking at you doing it. And then
mhm,
force plates, which these measure ground reaction forces during the test. So they can like
mhm,
they detect if you're like sitting, standing, how much force you're putting. And
mhm,
then our goal compared to like these is to validate sit to stand and prove why our software is better than current methods of sit to stand measurement. And then addressing conflicts in patient performance. I kind of mentioned this before, but partial stands analyze software's ability to detect incomplete movements and compare to physician observation. Because if someone isn't able to stand up all the way, a physician can obviously see that and account for it, but the software might not be able to account for it, and we should, you know, try to address that just to
mhm,
make it more accessible. And then recommendations for poor performance would be like suggest physical therapy exercises for strength and endurance and find solutions based on observed
mhm,
deficiencies.
mhm,
Um, Ensuring accessibility, test usability for patients with disabilities, such as giving tutorials or assistant for recordings. And then, because if we do this in like an app format, like just
mhm,
include a section like frequently asked questions or tutorials and give video tutorials, and then also maybe include a feedback form to improve software and usability. You know, it doesn't
mhm,
hurt getting feedback from actual users.
mhm,
Via reliability testing, this was just to make sure that our data that we're collecting is consistent. So repeat the test with the same participants over multiple sessions, and then validate consistency across different physicians and patient scenarios. Um, if we just this validate consistency across different physicians and patient areas, this is just because not all patients are the same. There's going to be patients are going to have have different circumstances, and it's just better to make sure the software is still getting reliable data through different
Mm-hmm.
perspectives. And
Okay.
then expected outcomes, um, correlation between software and physician slash gold standard results, identification of software strengths and limitations in different patient conditions, recommendations for integrating software into clinical and home settings.
Okay. I just added
Yeah.
note. Now, given this, so before I start, Sophie, do you have any comments or was it clear? What did you feel?
I knew that the sit stand method is already in practice in clinics and everything. Okay.
Hmm.
Okay, that's it. I don't have any questions for now.
Okay. Do you guys use sit to stand?
Not in my country, no.
Any reason? Do you know any reason why?
No, I'm not sure. So it has been practiced from before?
Are you asking me?
Yeah. How long
Like
has it been, this method has been implied
this,
on? Yeah,
the sit to stand, right?
yeah.
So it depends, right? See, it depends on the type of diseases that you're treating. In myositis, you have the proximal muscle involvement and you have thigh muscles that are damaged as well. So in that context, they use sit to stand to look for disease progression and treatment outcomes. So that is something that they're doing, and they've been doing it from quite some time. And not only for myositis, any proximal muscle damage, specifically lower limb, they do sit to stand. It's very easy to do, right? So that's the thing. So Hasini, you had some questions for me, or did you have what was
No,
the
I didn't have any questions. I was just like for today's session, I just wanted like feedback on like what I could do to improve the framework that I made.
okay? So I think the main thing is let's go from section to section, right? This
Mhm.
is, first of all, this is a good second draft, right? And then we have come, long way when it comes to how we are designing the study. So given that objective is more or less clear, but you need to be more specific when it comes to what our software is or what we are trying to do. So that is one aspect that you need to say. And then when you say gold standard, right? Either you compare it to physician observation or you name what the gold standard is. Right? So that is something that you need to add in the objective. Next, when it comes to significance, it's basically, yeah, I can see why it's there, but I don't know what extra it is adding,
Mm.
right? So when it comes to study purpose. So when you say study purpose, right, you need to say like you can go with the primary objectives and secondary objectives. So secondary objectives are, let's say you're already doing the study, right? And you're able to collect more information, right? What do you want to infer from the additional information that you're collecting? Those can be your secondary objectives, right? What you should add is you will be tracking the disease activity all and comparing it with the lab values that the patient is going to get. Okay. So in when it comes to study purpose, like objectives, you have your primary goals and your secondary goals. Secondary goals, you need to look at, okay, what is the best metric in lab value that will correlate with your disease activity? Right? That's the thing that I would say. Next,
Mhm.
coming to research question. So here you're asking how accurate are the software measurements compared to physician? Okay, that's pretty good. How does patient, this I really liked.
Mhm.
How does the patient movement quality? See, the reason why we are doing this study is because the only thing that we are able to infer with the current way of doing sit to stand is the quantity. the number of times that the patient is able to do it, right? There is very limited thing you can say when it comes to quality. You know how I would title this study? I would just be like, improve changing sit to stand from a quantitative test to, uh, something with respect to improving the sit to stand, right? So making it more quantitative. So basically, one of the thesis of our paper would be with respect to we will be able to comment regarding the quality of movement,
Mm-hmm.
not only quantity of movement. So that is something that I'm thinking about. But that was a really good, question. And it's not only so when you say quality of movement, right? The second thing that I will ask you is, what does quality of movement mean? Right? I want you to answer. One is partial stand. What else do you think quality of movement could mean?
Um, I think other
Mm-hmm.
than partial stand movement quality, it could be like, are they even able to stand without assistance?
Mm-hmm. Okay.
Mhm. And then, or it could be like, do they need to, I think a lot of like off the top of my head, if they need like they need to use their hands to stand up,
Mm-hmm.
or I don't know, what if someone doesn't have a leg or something? Oh,
Exclude them. Right?
oh, okay. Their exclusion. Or I mean, when I think of like the movement quality, I'm thinking mostly of partial stands because the software is detecting their height and comparing it to the time. So, oh shit, man.
That's just something that I'm just
Yeah.
thinking about, like, hey, can I see how much they're shaking, blah, blah, blah. So when we say like quality of movement, right, you need to say like what is good quality movement and then think about what a bad quality movement is. So anything that we need to be able to define. Does that make sense?
Mm-hmm.
Right?
Yeah.
And then in that case, see, if we talk about partial stands, that is something that we can make the physician also record. Do you agree?
Mm-hmm.
And what about shivering? We can ask them to record that. So
Yeah.
if we are asking them to record additional metrics, right? What else can we ask them to record? That's a question that I would think about.
Mm-hmm.
Right? Because you need to capture that information and then you can say that, hey, the software predicted the same.
Yeah.
Right? That is one metric. What accommodations are needed? So this I did not like because you should ideally be excluding these patients from your study in the first place. Okay? So because you will not have reliability, right? You will not be able to test what happened or you need to have something fixed. So this I will delete.
Okay.
Okay, then what else research question do you think we can ask?
Um, I can't figure it. How does movement quality, how accurate is it reliable? Yeah.
No.
I mean, disease activity, I would say,
Yeah.
and progression.
Yeah. So when you say disease activity, right? That is one thing. And the second thing would be progression, right? So how would you measure disease activity? You should look at for each disease, you need to look at, okay, what are the indicators for disease activity, right? That's something that you need to capture. So if you're not capturing those metrics, then we should not be commenting on disease activity,
Mhm.
right? Let's say, in Nepal, for example, they might not be doing all the tests, right? And they might be doing only one test, right? If you want to say, I want to comment upon disease activity and you're not having those particular tests that are the standard, they will not accept it.
Yeah.
Make sense? So that is something that you need to think about, Next, let's come to our inclusion exclusion criteria. Now, this is a place where I see a lot of improvement that can be done. You tell me how you would improve this.
Uh, mm, mm, I mean, I think it could be more specific. I think it's still kind of
Hmm.
vague.
Yes, it's very vague. I
Yeah, well, I
agree.
think like should be capable of performing STS. I think that's like a very broad term. I think it should be specific to what type of people do we want on our study and what type of people can provide us with reliable information.
Hmm. And okay, let me ask you this. Think about the best person, the most ideal candidate for you in the study. What does that candidate look like?
Mm, someone who is able to perform sit-to-stand without additional assistance, can follow the directions,
Hmm.
like they can follow the directions clearly,
Hmm.
and what else? And they don't have like another like condition that is going to like contradict the results. So as I said, like if someone had like a surgery or something, so like
Okay.
someone who just has a condition that affects their movement.
Okay. Got it. Now, you told me that, right? Now you tell me how your inclusion, and you are forgetting a very important thing. Read
Uh-huh.
your first point.
Adults above 18 diagnosed with myositis or related mobility impairments.
Okay. Or related mobility impairments. What does that mean?
Um, I don't know, just other like conditions that are like similar to myositis that kind of have the same like what are markers or symptoms.
No, you cannot say that.
Mhm.
When you say mobility impairment, right?
Mhm.
Then I will ask, why are you excluding people who had surgeries? Or why are you excluding people who had any XYZ thing that is impairing their mobility? So that's what, see, first, that is very vague, right? So you need to be as specific as possible. Adult, adults, people above the age of 18 years. Is that the right sign? Because that looks like it's less than 18 years.
Oh, I thought it was like this, the empty part would be, this would be like, oh, okay, that's my bad. Let me change that.
Yes. Yeah. Or
Mm.
you remove the bracket and put the adults over that side. That's something that you can do.
Because
But anyways,
how we're taught is the greater than sign's an alligator and it eats the bigger numbers, so it's facing towards the bigger numbers.
yeah, but you also know you should also
Include 18, right?
consider how
Mhm.
you're using your brackets, right?
Oh yeah. Oh,
So that's something that I would say. Again, I'm not 100% sure. So when you say diagnosis of myositis, right, I would even tell you be very specific about what type of myositis. Can you tell me what I mean by what type of myositis?
um, like what, like how it's affecting the muscle, or what
Mm-hmm.
muscle it's like, or what part of the muscle it's affecting.
Mm-hmm. I would say, think about what you're trying to assess, right? If you have a patient who has very severe myositis, he's not able to get up from the chair, is he useful for you?
No,
And think about a person who has very mild amount of myositis, is he useful for you?
no.
Not really, right? So you
Mm,
need to target the people with myositis who have moderate disease. Would you agree?
yeah.
Moderate can become severe, moderate can become mild.
Yeah.
You can detect change. So who should your cohort be?
Uh, people who have moderate myositis.
Yes.
Yeah.
So you need to write that in your inclusion criteria.
Hmm.
Next, you need to go and see what is the definition for moderate myositis. right?
Okay.
It could be with respect to, hey, someone who has lab values above so and so, clinical examination above so and so, blah, 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 right? So you can write moderate myositis.
Okay.
We can change that. Where- You need to expand more on top of that, but that's something that I would say, right? So when you define moderate myositis, that's where you are getting more and more points.
Mhm.
Okay. Here, so minimal assistance. So see, this I agree with, but what does assistance mean? Right? Like, is it like a other friend, other person who can help them? Is it like a chair that you are giving them? What is it?
Yeah, like the first thing that come to my mind is like another person
Hmm.
or holding onto chair.
Okay. Now you tell me, of these two, which do you think would be more consistent?
Holding onto the chair.
Yes. So you have to eliminate the another person,
Okay.
right? So you should not call it minimal assistant. The only assistance allowed is they can hold the chair. So that's what you need to say when you say that, hey, with assistance, without assistance, right? This is something that you need to define,
Okay.
right? And the next part, I will ask you this very interesting question. How do you know that the person's disease activity will change? What are you, what is the time frame in which the person's disease activity will change?
I think it was like, didn't we say like 2 weeks?
Did you say two
I
weeks?
know we talked about this last time, and we said something about 2 weeks, like doing a test within 2 weeks to limit like the data being skewed.
Yep. And then I was having this debate with my mentor. I was like, so there is this blood pressure cuff. You get a heart rate in that BP cuff, as well as you get a heart rate through your pulse oximeter. Right? Pulse oximeter is the thing which will give you oxygen saturation as well
Yeah.
as heart rate. Right? I do want Kushala also, she's here. Which heart rate is more reliable? Kushala?
The
I think we should let her answer first and then I'll answer.
Okay. Yes. Go
wait,
ahead.
wait. So the pulse ox and then what else? The cuff.
The cuff.
Um, the cuff.
Okay. Kushala?
Yeah, I want to ask her why do you think the cuff is better?
Mm, I think like the cuff is putting the pressure, like direct pressure onto like the arm, but then the pulse
Mm-hmm.
ox, it's just on the finger. Like even for
But
me,
it's
whenever I have to take
mm-hmm.
blood pressure, I'm still confused on how the pulse ox like detects blood pressure.
It is a pressure sensor, but it measures it, from the arteries in the fingers. Whereas your BP cuff will measure a bigger artery in your arm. Now, can you tell me why you would prefer the cuff to the finger, like the artery in the arm to the artery in the finger?
Like we were just saying like the cuff measuring like a bigger artery. I feel like maybe
Mm-hmm.
that might be more
Versus
accurate compared to like the finger.
no. It's kind of the same unless there is an issue, but
Mhm.
usually the pressure that gets like the heart, it always correlates with the heart rate and it gets transmitted uniformly throughout the body, right?
Mhm.
So it's not about the bigger artery or the smaller artery. I think, yeah, now Kaushik, like, do you want me to tell the reason?
I would say the let me ask you a follow-up question, right?
Mm-hmm.
Where do you think the patient will make more mistakes? Which one will they make more mistakes on using?
Oh, the cuff.
Yep.
Mm.
Really? I mean, I'm asking Kaushik, like, why do
Yep.
you think, like,
It's not why do
once,
I think. That is true. That's published
or is it,
research.
oh, okay. Because I just thought once the cuff is in place, they
If it
just
is in
sit tight.
place. Yes.
Okay,
If it is
they
in
don't,
place.
okay.
Oh, yeah, because don't you have to, isn't there like a specific way you have to like wrap it around for it to accurately detect blood pressure? I don't even know. I've gotten it wrong so many times.
Exactly. So if
Yeah.
you are putting it wrong, how do you expect right results?
Mm, that's true. That's true.
Now I'll tell you what we did. This is very interesting. I asked Rohit. I was like, you have one database, right, which is reliable. We have another database. You're making research coordinators do manual data entry. Why can't we define metrics and say that, okay, export from here to there? That's it, right? You don't have like, error where the research coordinator enters wrong. Now, what they decided at that meeting was we are going to make the research coordinator enter the heart rate from the BP cuff. And they told one postdoc to go and do literature review regarding which is better. Right? And then that's number one thing they did. The second thing they did was when I asked him this question, why are you not exporting from one place to another place? He told me one thing. He was like, when I'm collecting more data, I'm seeing that this person is not doing properly. So heart rate is fluctuating too much. There'll be times it goes above our threshold and below our thresholds as well. So each time it goes above or below our threshold, if we are recording that information, we have to report it as protocol deviation. Each time it does that. So he was like, rather than making the patient do too many times, do once a month. Right? So that's what he said. And then when I read these papers, I was like, it makes so much sense that hey, this patient is going to make mistakes, they're not going to put it properly, and that's the reason why you're getting bad data. But when it comes to pulse oximeter, it's very easy to do and it's very hard to make mistakes, so that is more reliable. So we need to go and present on Tuesday again and tell that hey, I don't we should not be entering the heart rate from this, we should be taking from pulse oximeter.
Hmm.
Right? So these are the things that you should think about beforehand with respect to, hey, what is the data that needs to go? Then I asked him, I was like, tell me this. If there are multiple different heart rates or whatever blood pressure, who makes the call? He's like the research coordinator makes a judgment saying, is this heart rate accurate or not?
Hmm.
That is why there is manual, entry. Then I was thinking, is he making it up or is it like really true? And I was like, how do you know that, right? How can you come up with it just like that? So it looks like that's the case. Make sense?
Yeah.
So what I learned was things will make logical sense. That is why they will still want you to do research and then figure out if it correlates or not.
Okay.
Make sense? So that's the reason why I'm telling, we need to be more specific and more clear, and we need to define whatever definitions we are using. And a definition we can make up doesn't matter. As
Mhm.
long as you define it, it doesn't matter. Make
Yeah.
sense? So that is the thing. Next. So we need to update the inclusion criteria. And do you recall from our past sessions, like what does our exclusion criteria do?
Establishes um who are not included in the study.
Why are you adding exclusion criteria?
Um, I think to specify like the parameters in which this like we that were used
Mm-hmm.
with like the data and stuff.
Mm-hmm. Now think about how you're going to get the group, right? See, just imagine your inclusion criteria. Who do you have now? You have adults.
Mhm.
Will you have kids? No,
No.
right? You have adults who are having moderate disease of myositis.
Yeah.
Do you agree? This is your group.
Mhm.
Now, in this group, who can't you test?
In
Someone
adults.
with known arthritis,
Um,
someone with, some amputation, someone who's undergone like recent surgery. How recent you need to define, right? So that
yeah.
becomes your exclusion criteria.
So exclusion criteria is like what is making your inclusion criteria more specific, basically.
Yes, yes. Then you can ask me, hey, why can't I just rewrite my inclusion criteria? Right? But the thing is, the idea behind exclusion criteria and just add pregnant women. Just, you'll always be right if you add pregnant women into your exclusion criteria. Yep. See, very smart. You added only pregnant women. Okay, got it. So you have kind of mentioned it, like recent lower limb surgery. Now I'll ask you a question. Okay. What are we doing with our study? We are trying to comment upon disease progression. If
Mm-hmm.
that person has one limb with assistance, do you think they can get up? They
Yeah.
can get up, right? Let's say surgery was done 5 years or 10 years ago. They might be wearing prosthetics.
Mm-hmm.
They will be able to get up.
Mm-hmm.
Now, how does their surgery affect the disease activity?
Because they
Let's
don't have
say
any muscle there.
initially, yeah, I mean, they still have one leg, right?
Oh yeah.
So you can still, they're still doing something,
Mm-hmm.
right? With respect. So my question is, if you are telling me I want to like lower limb surgery, I want to ask you, who can you include of the people who underwent lower limb surgery?
Um, I mean, like for example, if someone had lower limb surgery like 10 years ago and
Mhm.
they needed like PT and they did all of that and they're back to normal, or not back to normal, but they're
Mhm.
able to like function day to day without like assistance or
You
extra
know,
things.
what I caught from your thing? I would just be like, patients not undergoing physiotherapy or for any other condition, right? But that's something that I still need to think about, but we can just add that. So that is how I would say, we can do the exclusion criteria. The other thing that we did not comment about, I'm still waiting for, is disease activity. When it comes to, why are we saying 2 weeks or 1 month?
Mm, was it like we had this conversation? It was like does depending on how it all just depends on like how the disease progression is from person to person, but just I think generally, there could be a lot of like a lot of difference in like 1 month.
Hmm.
But I think honestly, in my opinion, I feel like 2 weeks also might be too much.
Hmm. But let
We
me
also
ask
have
you
to
this. Yeah, yeah. Go ahead, go
we also
ahead.
have to account for like how often pe like the participants or just people in general are gonna want to be doing this.
You need to think about, see, if it's a study and they enroll, right? You expect
Oh, they
that
kind
they're
of have
gonna do
to.
it.
Yeah.
Yeah. Now my question would be with respect to, hey, I get that you're gonna do this, right? How are you standardizing that your patient cohort is similar? See, they won't be the same, right? You need to be as
Mhm.
consistent as possible. Just give me a second. Think about it. I'll come back in a second. Yeah.
Mm, I think in one way, it's like we're establishing that we are going to do a study on people who have moderate myositis,
Hmm.
and I think, with age, well, no, because adults is pretty wide range of people.
Okay. Think about when you go for follow-up for a doctor. What is the reason why you're going?
Because mm, usually I go for a follow-up just to see if I got better.
Yeah, you got better. And then if you get better, what does he do?
Actually, I don't know. I don't really
Does he
go for
add
follow-up.
medication or
No,
decrease
he
medication?
decreases medication.
Decrease medication. So what is one variability that will be there in our study? The number of medications they're taking that is influencing the disease, right? It could be that they're taking 3 steroids versus 4 steroids versus 5 steroids, right?
So, in
Go ahead.
addition to them having moderate myositis, you would also have to make sure that everyone's taking the same amount of medication.
Yep.
Okay.
Now, how you make sure of that is based on, see, think about it this way, right? Let's say you're seeing patients with myositis and you're
Hmm.
calling them moderate disease, right? On what basis what is the reason for calling them moderate disease? Because you want to give them treatment. Do you agree?
Yeah.
Given that is what you want to do, the type of treatment is going to change based on the severity of the disease,
Yeah.
right? So if you're calling moderate disease, I would also need to know what is the criteria that you're using and what are the different types of medication they're on. One is medication that's going to affect your disease. Others could be, you had a cold, you're taking cold medicine, blah, blah, blah. So those cold medicines you don't really care about, right? You care about myositis specific medication. So they will be taking steroids. They will be taking other types of immunosuppressants. When I say
Mhm.
immunosuppressants, basically they are reducing your activity of your immune system, right?
Yeah.
So I would like to know in the inclusion or exclusion criteria, what is the allowed medication that the patient can be on? Right? In inclusion criteria, do you put, now you tell me, do you put that in inclusion or exclusion criteria?
Inclusion.
Okay, you put it on inclusion. What do you put in exclusion?
Mm, say like, I don't know, for example, if you want, they can only take 3 steroids. Exclusion criteria is anyone who takes more or less than 3 steroids.
No. See, then you're calling this, see, you're just rephrasing inclusion, exclusion criteria, right? But that's not the
Mm,
goal.
exclusion, if we
Think
wanted
about
to take
what I
more.
said in few statements, right? I was like, hey, do I care about the other medications that they're taking?
No.
Inclusion
Yeah.
criteria is not giving you that information. What will exclusion criteria give you? It will tell you what are the medications that are definitely the patient should not be taking, right? It could be that, hey, that is influencing your study outcome. In our case, it's not there, but in if you're doing any medication study, that will have side effects. The study medicine will have side effects with the other medications that the patient might be taking,
Mm-hmm.
right? So that is the reason why they put that in exclusion criteria.
Okay.
Okay. For us, it's not there. Just letting you know.
Mm-hmm.
You can find and let me know if it is there, but I don't think so.
Did I word that right?
Severe cognitive or vision impairment preventing. Yeah, that's pretty good. Physical condition that contradict with. So you should not use so much English over here.
Things that
Make it
contradict
as,
what the
yeah, should make it as simple as possible. Leg, no leg, one leg. I mean, that's like, too simple, but, try to make it as simple as possible.
kidding.
You don't know, like, yep. Then when it comes to data collection and setup, you have before testing, and
Yeah,
where is after testing?
yeah, when you said it out loud, I kind of realized I didn't have good testing.
Okay, what will you do after testing?
Compare the data from the initial to the data
No,
collected during testing, and
no. What else would you do?
mm, after we tested,
You can give a post-study questionnaire and ask the patient's experience about the study,
mm,
right?
so would the post-study questionnaire kind of be like, hold up 1 second.
Did you have any issues performing the sit to stand?
Sorry.
It's okay.
What was your question?
You were asking me a question.
Oh,
You
what was
were
I?
like
I don't even
post-study
remember now.
questionnaire.
Oh yeah, yeah. So is it like kind of like a feedback form? Like what can we do to improve not just the study,
No.
but just like application?
I mean, I would say a post-study questionnaire is think about the components of the study that the patient had to do, and
Hmm.
then think about, what the patient would have faced issues in. If you're employing an app, right? Did they have any issues uploading? Did they have to do it twice, thrice? Did it ever break? Blah, 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 right? And what challenge they faced with, being part of the study. No, so when it comes to testing, this is what I thought in my mind. So what are we keeping constant in the sit to stand test?
Then what like in the like inclusion criteria, just like doing the test in general.
Doing the test, the sit to stand test. What are you
Um,
keeping constant?
they have to not use their arms. They have to like put it
Hmm.
onto their shoulders, right? Or in X.
We were telling that we would be able to capture that, but what else are you keeping constant? You have told 5 repetitions.
Oh yeah.
Is that what we are keeping constant?
Are we keeping time constant?
Yes.
Yeah.
It's 30 seconds, right?
Yeah. Yeah.
So you need to mention that and say that we are keeping it as 30 seconds.
Okay.
Hmm.
Mhm.
So this is an interesting point. Hmm. I need to think more and I need to look into it more. So basically, what you're saying is, can I create an environment where the test will be more accurate? That's the question, right? With
Mhm.
this?
Mhm.
Hmm. Okay. I don't think it's required, because it is accurately able to detect the human and segment the human out. So I don't think this is required. This will be an advantage for us and
Yeah.
say that, hey, we don't need any tool. We are able to get the human accurately,
Yeah. Like the
right?
reason I Yeah, the
Hmm.
only reason I had this was because I know on your presentation that it showed that on your just on the regular computer it was kind of a little fuzzy, and then on the super advanced one it was very clear.
Hmm.
And yeah,
Yeah.
not everyone like has a supercomputer.
Yeah, I mean, yeah, I get it. I understand, but that's true. But we are hoping that we can, ship it through the better,
Yeah.
better test. So then conduct test at consistent time to minimize variability. So let me ask you this. Have you seen people, do you know why people keep their pills in the washroom? Do you know people keep pills in the washroom?
I don't keep my pills in the washroom. I keep it in the pantry. I mean, probably just so they remember. Like you go to the bathroom like every morning to brush your teeth. So it's like you just remember to take it.
Yes, that's the answer.
Yeah, just
And then they did study on that. You believe it or not, right? It
let's
seems
Google
like
that.
common sense, but you should not assume that, right? So basically, so you're saying that conduct test at consistent time. So if you say that, you should tell me why. When you say minimize variability, right? What
Very vague.
variability are you looking at?
Mm, I mean, for example, at the
Mm-hmm.
end of the day,
Mm-hmm.
like I'm super tired and I
Mm-hmm.
might stand up slower than if I were like fresh and awake. So if I do sit to stand like in the morning one day when I'm all like, refreshed and then like 2 weeks later I do it in the night, but I'm super tired, obviously there's gonna be like a difference.
Then I will ask you, why don't you make the patient do it twice
Like once in the
in the
morning, once.
morning and night?
Well, because each day you do something different. Because
Yeah.
maybe one day I went on a run and the other day I just laid in bed.
So what should you tell over here? Your study should give instructions on when to do the test.
Hmm.
Then you should say that, hey, don't do it when you're tired. But when you really think about the disease, right? If you're thinking about someone who has moderate disease, see, these are the people who can probably stand up 4 times in 30 seconds. Now that's already very bad, right? So given that is their condition, I don't think they would be, doing a lot of physical activity,
Hmm.
right? That's something that I would say. So our after testing questionnaire, that will be your after testing, is not only your post-study questionnaire, it is also you could have, we did this. What is the questionnaire that we had used for after testing? Do you recall for the FI3? Do you remember? They
I'm
had
not
a
gonna.
questionnaire, Borg scale.
Oh, the Borgs. Yeah,
Yes. Why did they have the Borg scale?
to know how tired was it? How tired they felt?
Yeah, after the test,
Yeah.
yes. So you should think about any of those tests. I would just put in the Borg scale.
Oh, I was gonna write.
So post-study questionnaire will just be in the end, and then the after testing you will give them the Borg scale.
Okay.
Then when you go before testing, you will collect demographics, disease history, serum markers. I don't know aldolase. I'm not sure how many
If I'm
people
being
would even do that.
if I'm being honest, I Googled that because you mentioned it last class and I just Googled serial markers for myositis and I just wrote two.
Okay, that's good. And yeah, that's okay. I mean, you can look up other markers as well. I've just not had the time to do it.
Yeah.
It's been 4 months already, and high time I read up about this disease. I'm dying over here. Yeah. So anyways, before testing, that's pretty good. Baseline physical function. Huh. This is very interesting. What do you
Mhm.
mean by baseline physical function?
Mm, Probably just like the starting point.
Mm-hmm.
Because like this, I was thinking in like relation to like experiments, you always have like the control group. I would say maybe this would be the control group. I don't know.
How? No, I'm just thinking like
That's
how.
mm, I think you have your starting, and then when you measure the data, you could be like, is this person getting better compared to when they started, or are they getting worse compared to when they started?
You know what I would say we
I
would
feel like,
need, and this is something that we have not included, is what is their height when they're fully standing?
oh, let me write that down.
They can use assistants to stand up. They can take as long as they want. You should have their, height when they're fully standing because that
Yeah.
will be your comparison, right?
Mm-hmm.
Yep. Next, gold standard. This will take some time, but okay. When it comes to gold standard, I would not call it gold standard. I would just call it, physician assessment or current assessment, right? I would say that, okay, physician is assessing so and so measures. Here, see, this is where, so like you're calling it tools for comparison, right? Number
Mm-hmm.
one, most commonly used one is the physician assessment. All the other possible tools that are out there, you need to put that over here,
Wait, put it
right?
where?
It could be, we had done a literature review. Are you keeping the literature review or are you reading a paper and then forgetting about it? Reading paper and forgetting about it?
I like, no, I mean, I kind of, when I read the papers, I keep in mind like kind of the general stuff, if that makes sense.
Hmm.
Like what is like the overall, like what are they telling me?
Can you open spreadsheet?
Just like a new one?
Yeah.
What is that? Sheets.
Oh yeah.
Mm.
What I would say is, yeah, in the sheet, you read a paper, right? What are the things that you're looking for in that paper?
Oh,
What do you look for?
um, probably like their objectives.
Mm-hmm. Okay.
Okay.
Next.
Goals, methods.
Okay.
Um, after the goals, methods. I look for their limitations.
Okay. Why are you looking at limitations?
I just want to see like if what I'm reading is actually valid.
Okay.
And I want to see if they're able to identify what they need to work on. See, for me, I feel like that's what is um like an indicator of a good study or at least a good team because if you're able to identify your limitations and address them, that just shows there's like you agree that there's room for improvement.
Okay. Got it.
The
So
green
I
flag.
would, yep, I would say if you're looking at these things, each study is going to be different, right?
Yeah.
So I would say things that you need to look for is the device or the method used for sit to stand assessment, right? And then in the limitation, I would call it like, specific to our study. What do you think their limitation was that our study can address,
Mm,
right? If you're capturing limitation anyway, I'm not asking you to do anything else. I'm just saying that, hey, at least the limitation that our study can address, you need to put that into Excel. And you need to have a citation for that paper and the year that it was published in.
okay. I'll fix this later, but
You remember we did the Japanese paper right? So when you say the method, when you say the method, you need to look at the software tool that they've used, right? So that's what I mean by, hey, method.
Mm.
So for the next class, I would say you can compile all the different tools and then send me the Excel spreadsheet, and then I will organize the titles for you. Okay, but these are, see, I didn't add anything that you were already not seeing, right? You were
Yeah.
already looking at those things.
Mhm.
And this I usually do when I feel like, okay, hey, you need to do more when it comes to other methodologies. And then this will be a basis for you to write your paper.
Do you want me to find like
Yeah,
new papers, or do you want me to just use the ones
yes.
I've already found?
You have to put the ones that you've already found. Those were like four or five, right?
Yeah.
Yeah, all those four or five should go into this Excel, and I'll send you a demo like the one that I had made. And
Mhm.
then you think about, hey, now see, what did we finalize? We finalized our method to a major extent. Then in that method, you're looking at disease activity, the medication that the cohort is in, what medication they're taking, and that is giving you an accurate depiction of who your cohort is.
Mhm.
Right? So I would encourage you to look into other papers and then look for the same trends. That hey, what was the cohort that what was the cohort of the patient that they were looking into,
Mhm.
right? And then what did they employ or what particular technology did they use, right? That's what I would say. So
Oh.
yeah, that's about it. For next class, we'll go over the, your literature review
Mhm.
and we'll see, we'll yeah, and we'll go over the next parts. But honestly, this is a pretty good draft,
Thanks.
right? So that's about it. Before you leave, I do want to ask Kushala. Kushala, do you have any comments or any suggestions?
Um, Not really. I just want to know if she understood, like when you're setting a criteria, like even every word you use needs to be backed by research. Like, does she I want to know if she understands the value of that. I
Yeah.
think that's important for, like, that's the only takeaway that like when I did my first paper and I went to the statistician, he was like, why are you using this? Why are you using that? Do you really need this? Like every word that you write on that paper needs to be backed by research.
Mhm.
So if you can understand that, then I think, yeah, you're on a really good path. Like you'll be a good researcher.
That's the reason why I think we highlighted those.
Yeah.
Anything that had subjectivity. And the another thing,
Yeah.
Hasini, would be anything that you feel can be left to interpretation. You highlight that. Anything.
Okay.
Okay, this is where ChatGPT is very bad at. It will make up vague shit,
Yeah.
right? That's something that I would say. Sophie, what did you think about this? And then